Hello there, my name is Geffrey Klein. I'm a board-certified OBGYN with over 25 years experience. Today's video will be discussing informed consent for hysterectomy. Before we get into the specifics of hysterectomy, let's talk about the concept of informed consent. An informed consent, to be valid, needs to be voluntary and also explicitly written. There can be no coercion of the patient, and the capacity to understand the information needs to be assured. The physician's responsibility to the patient includes the disclosure of the diagnosis and the planned procedure. The benefits of the procedure and the risk of the procedure need to be presented, and the likelihood of those risks needs to be outlined. Relevant alternatives to the procedure and risk of no treatment round out the factors necessary for an adequate informed consent. Perhaps you are here because you've already made the decision to have a hysterectomy, or you're thinking about having a hysterectomy. Common diagnoses that result in hysterectomy include uterine fibroids, endometriosis, heavy and or painful cycles, cervical dysplasia or precancer, uterine prolapse where the support of the uterus is lost, and any type of gynecologic malignancy. At this time, you've probably already discussed the planned route of your surgery. There are multiple approaches that can be used to do a hysterectomy: abdominal, vaginal, or laparoscopic. The abdominal approach uses an incision in the abdominal wall, either side to side or up and down. Vaginal approaches are exclusively through the vagina and leave no scars on the abdominal wall. They may be a little bit harder to perform with larger uteruses. A laparoscopic approach uses small incisions in the anterior abdominal wall for a minimally invasive approach. The uterus is then removed through the vagina. The route your doctor and you choose has a lot to do with their level of comfort, what the underlying anatomy shows, and any underlying medical problems. Before continuing, I'd like to just talk about a common misconception that the public has about hysterectomies. Patients will come to me and they'll say, "I'd like a complete hysterectomy." But I think they're probably referring to removing the uterus, the cervix, both the fallopian tubes and both the ovaries. But what they're asking for and what they think they're getting are slightly different. So I'd like to clear up a little confusion about what's going on. When you remove the uterus or part of the uterus, that's the hysterectomy part. A total hysterectomy is when you remove the uterus and the cervix. A supracervical hysterectomy leaves the cervix behind by transecting above it, removing just the uterus itself. A radical hysterectomy is outside the scope of this discussion because those are almost exclusively for gynecologic malignancies. These are procedures that a generalist generally does not perform. When it comes to classification of surgeries performed at the time of hysterectomy on the tubes and ovaries, those are separate procedures. Removal of an ovary is called an oophorectomy, and removal of a fallopian tube is called a salpingectomy. That can be one-sided or both or neither. As an example, if you remove both fallopian tubes, that's considered a bilateral salpingectomy. But if you remove one tube and one ovary on the left side, that would be called a left salpingo-oophorectomy. So now we're going to talk about the benefits of hysterectomy. The hysterectomy was done for heavy menstrual cycles, well, that will be completely fixed. Dysplasia and fibroids are almost always treated, although there's a potential for recurrence of dysplasia in the vagina afterwards. Gynecologic pain, however, is a little more challenging because if somebody has pelvic pain and it's not from the gynecologic source, i.e. the bladder, the bowel, or some musculoskeletal issue, doing a hysterectomy may not completely relieve the pain. Uterine prolapse, that can be treated, but vaginal prolapse can occur at a later date. And successful treatment of cancer depends on staging. Most of the consent forms are going to explicitly state that no warranty or guarantee of cure will be made. Let's talk about the risk of hysterectomy. This is where you run a fine line between adequately informing your patient and scaring them too much. But for the purposes of this video, I'm going to present all of the potential risks so that you're adequately informed. Just don't be too scared. All surgery has risk. The main risks for all surgeries are anesthesia, bleeding, and infection. Any procedure will have those risks. Bleeding is a risk with hysterectomy, and it could require blood transfusion. Now, blood transfusions themselves can carry the risk of HIV or hepatitis and transfusion reaction and organ damage. It would be a good idea to consider asking your doctor about donating blood for yourself or having a designated donor provide blood for you as a more trusted source. Women who have a hysterectomy must be aware that they'll never be able to get pregnant again and that the procedure is not reversible. Removal of the ovaries also may result in a surgical menopause with hot flashes, night sweats, and osteoporosis or bone loss. And up to 5% of women who conserve their ovaries at the time of hysterectomy may need to have them removed later in life because of pain, cysts, or ovarian cancer. So with the hysterectomy, there are also very specific risks of infection. That occurs in about 9 to 13% according to some of the research studies. That could include just wound infections or deep pelvic infections or abscesses. Urinary incontinence is possible, but not very common. Bladder injury occurs about 1 to 2% of the time. However, that's fairly easy to fix and doesn't usually result in any long-term problems. The tube that drains between the kidney and the bladder is called the ureter, and it runs very close to the blood supply of the uterus, so it's possible it can be injured during the hysterectomy and may not even be recognized at the time of surgery until later. The risk of that, according to most research studies, is about 1%. Intestinal injury occurs in less than 1% of the cases and can result in a very serious infection. Completion of the procedure through a large abdominal incision can occur if you use a minimally invasive approach, such as laparoscopy or vaginal approach. Damage to nerves occurs in about 0.2 to 2%, and injury at the site of a trocar can occur if you do a laparoscopic approach, such as damage to a blood vessel or a nerve. When the uterus is removed along with the cervix, the opening of the vagina is a cylinder, and it requires suture along the top of that to create a cuff. And in about 0.4 to 1.3% of the cases, it doesn't heal adequately, and the cuff can open and cause bleeding or pain, or in some instances, some abdominal evisceration through the vagina. That occurs about 0.4 to 1.3% of the cases. Another potential complication is thromboembolism. This is where a blood clot forms in the leg, in the deep veins in the leg, and then can potentially become dislodged and travel through the heart into the lungs. And that is potentially fatal complication. It's due to pelvic surgery and lack of mobility, causing stasis of blood flow through the veins. And we take lots of extensive measures to try and prevent the formation of blood clots in the legs by using compression stockings and a sequential compression device which moves the blood through the veins. Allergic reactions occur, and according to most of the research, the risk of death from hysterectomy is about 6 to 40 per 10,000. You'll see a higher rate of in patients who are sicker or older or those with cancer. Informed consent is incomplete without presentation of relevant alternatives. In the absence of cancer, most hysterectomies are performed to relieve troubling symptoms that interfere with life's daily activities. However, for the treatment of cervical dysplasia, there are some less aggressive surgeries that can fix the problem, such as loop excision or cervical conization. Uterine fibroids sometimes are completely asymptomatic and require nothing more than expectant management, which is watchful waiting, unless there's pain, bleeding, or urinary incontinence. Patients with symptomatic fibroids may also respond to uterine artery embolization, which is a radiology procedure to occlude the blood vessel to the uterus, or therapeutic ultrasound. Endometriosis, heavy menstrual cycles, and fibroids may respond to medical therapy. And endometrial ablation for heavy menstrual cycles is a less invasive way of controlling bleeding and effective in up to 95% of patients. Pessaries are appliances that can be placed in the vagina to help relieve uterine prolapse. This is a good choice for somebody who has a lot of illnesses or is elderly. If you're uncomfortable with the decision to do a hysterectomy, you should consider getting a second opinion. The final component of informed consent is a presentation of the risk of no treatment. Patients with a cancer diagnosis risk progression of the malignancy if they don't have a hysterectomy. However, most hysterectomies are performed for benign indications, as we discussed earlier. You have to get out your scale. If you're fully informed and you know all of the risks and still the benefits outweigh those risks, then you should proceed with the procedure. Only you can decide to do the surgery, and that's what I usually tell my patients.